Cast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our June 3rd Thursday webinar. We're excited to have Megan Stuff with us today from the Southwest Medical Imaging to talk about not letting a good crisis go to waste. Before we get started, I have a few things to go over. First of all, we did put a handout in the materials. It's either on your control panel, or if you look at the three dots where it says more and hover over that, you'll see where materials are, and you can go down there and you can download a PDF of the presentation that we're doing today. We are also recording this session. If you have any questions, please type them in the question box and we will make sure that Megan gets those questions. And today we're going to introduce our speaker. We have a few announcements to make. We'll have our session then, and then we'll close the webinar up with questions that you may have and introduce our next webinar. As a reminder, we have several programs supporting this. We have the California Council for Excellence, Oklahoma Quality Foundation, Partners in Performance Excellence Northwest, Quality Texas Foundation Regional Program, Rocky Mountain Performance Excellence, Sterling International, and the Partnership for Excellence. And all of our programs have ongoing activities. So please visit our website. You can see the links here and get engaged with your program. One of the things coming up is our conference for TPE is coming up in September. So if you're from the TPE area and would like to join us, it'll be September 14th and 15th in Columbus. I'm also waiting for some graphics, but I do want to announce that the Alliance Baldridge Conference is going to be in October. On October 12th and 13th in New Orleans. So we will have more information on that coming forward, but want to make sure if you're interested in that, you get it on your calendar. We'd like to thank all of our organizational members. They allow us to do the work that we do to assist organizations on their performance excellence journey. And most of our programs are 501(c), so we greatly appreciate the support of our members, applicants, examiners, etc. So thank you to all of you who support our programs. I would now like to introduce Bob Mitchell with REMPEX, who is going to introduce Megan, our speaker.
Thank you, Margot. Yes, it gives me great pleasure to introduce Megan Stuff. She's from the greater Phoenix area. I'd like to introduce Megan. She's the Chief Operating Officer at Southwest Medical Imaging. Megan has spent more than 20 years in radiology, starting her career as a technologist and growing into executive leadership. She is passionate about improving patient care, supporting healthcare teams, and finding innovative ways to expand access to imaging services. In addition to leading operations for one of Arizona's largest outpatient imaging practices, Megan is also an advocate for MRI safety, healthcare leadership, and women's heart health through her work with the American Heart Association. Known for a practical approach and genuine passion for people, Megan brings both operational expertise and a real-world experience to help today's discussion. Please join me in welcoming Megan Stuff.
Hi, everyone. It's so great to be here. I am joining you not from Arizona. I'm joining you from Cape Cod. I am visiting the wonderful Northeast, so this is such a treat. I am talking today about a saying that has been true to my heart: never let a good crisis go to waste. And this is a way that we are able to leverage external failures and drive measurable safety improvements in radiology. All right, so Rob did a little bit about me, but here's a little bit more about me. As alluded, I am a technologist by training. I am an X-ray, CT, MRI technologist for over 20 years, and I also have my MRI safety officer credential. I am the Chief Operating Officer for Southwest Medical Imaging. We are a physician-owned 16 outpatient center facility in the greater Phoenix area. We expand all over the suburbs in Phoenix. We have over 700 employees, and we perform roughly 700,000 exams every year. I obtained my master's in organizational leadership and have been in leadership within the organization for about 15 years. And one thing that has given me a lot of leadership experience is that 8 years of a Girl Scout troop leader. This is something that I have learned arguably more in Girl Scouts than I have in any other leadership role. I also am a part of the American Heart Association. It's an organization that is just very, very dear to my heart. All right. So the philosophy, never let a good crisis go to waste. I had a mentor that used to say this. He used to say this a lot. And I did a little bit of digging of where did this come from? Now it's unsure of who said this, although it's often attributed to Winston Churchill in the World War II era. But basically, what this means, never let a good crisis go to waste, is that a crisis can cause damage, but it also creates a window for significant and lasting improvement if managed strategically. Now, I want to take a little bit more and do a little bit more expanded meaning here. When I think about never let a good crisis go to waste, I think that the best leaders don't just learn from their own mistakes, they learn from others so that they can prevent mistakes, those same mistakes happening either to themselves or their organization or their lives. So this brings me to what I wanted to talk to you about today is the failure analysis critique team. We call it FACT team, failure analysis critique team. So at SMIL, I'm going to say SMIL, you see the logo there, Southwest Medical Imaging. So that's the acronym that we say. SMIL, we have put that expanded meaning of never let a good crisis go to waste, learn from the mistakes of others. We have put that into action. We formed a multidisciplinary committee and we ask questions of what if this happened here? What if this happened within the walls of our organization? And in doing so, we were able to uncover latent risks and identify vulnerabilities in our system and implement solutions before harm occurs. Today, I hope that by the end of the session, you will be able to understand the importance of a root cause analysis. And that's a little bit remedial, especially for this group, but it's very important still that we get back to the building block basics. And I would like for you to be able to build a FACT committee, a failure analysis critique team for your organization. Apply case studies that drive measurable improvements that we have used at SMIL into your organization, and use tools and templates to facilitate discussions and track interventions within your organization. So the basics, like I said, we need to get back to the basics, the root cause analysis, what it is and why it matters. Okay, a root cause analysis, an RCA, is the foundation. It is a structured approach to identifying the underlying causes of an event or an error or a near miss or anything, basically identifying what actually happened, not the symptoms of what happened. In healthcare and in radiology specifically, a defined RCA, it promotes a culture of safety, accountability, and really understanding the why behind issues that occur within your organization so that you can prevent them and implement sustainable change. Now, without a consistent RCA approach, organizations risk repeating the same errors over and over again without really understanding why is X happening here. So root cause analysis is the foundation. So I'm going to pause right there for a minute. At SMIL, of course, we have an RCA team, a team that looks at all of the events that happen within SMIL. So the fact analysis critique team is an offshoot of our RCA team, if you will. All right. So again, some foundational root cause analysis key principles. Multidisciplinary. When you have a root cause analysis team, you need to have different people. You can't just have the people who are the executive leadership, or you can't just have the managers or the supervisors. You do need to have the people there that actually perform the job. If you don't have the people there that perform the job where the incident happened, then you won't really know the possible causes of the root cause. So again, sometimes when I talk to other organizations, they just have a little bit elevated leadership doing their RCAs, and it's really important that you have maybe frontline person, or definitely the people who do the job, so that you can understand and that you don't miss the truth. Psychological safety. This is something that is very important to me in all aspects, but within a root cause analysis, it is really important that you have psychological safety within that team. You don't want people to get defensive. If you get defensive, then I think that maybe people withhold back the truth or withhold back facts, which leads into the next. Don't jump to conclusions. When performing root cause analysis, the first answer rarely is the smoking gun. It's usually not the one that's going to drive the change and help you find what really happened. Additionally, symptoms, not individuals. Human error is almost always a symptom. We all know this. We know that human error isn't usually the reason, and it's not usually the root cause. It's a symptom of one of the, underlying issues. I like to ask why multiple times. This is something going back to my Girl Scouts. I ask my Girl Scouts all the time, well, why? And then when they give you the answer, well, then why? And then when they give you the another answer, you say, well, why? And the whole point is to try to drive all the way down to the actual why. And then measure. An RCA without follow-up is merely a discussion. This is something that is so important, and hopefully you are all doing in your RCA process. Now, I know that everyone has their own RCA templates, and I just wanted to do a little show of what we do for our RCAs at SMIL. Obviously, we want to look at the series events, what happened, the timeline, contributing factors. Now, this is just a really organized, methodical approach to what I just said on the previous slide of keeping it structured. And then what were the steps, the timeline, contributing factors, and then you look at it and you go from there. And then the incident assessment scoring. Now, some events are not, they're very unlikely to ever happen again. So it's really important that the probability for future occurrence, when you look at this, is it a major, is it moderate, is it minor? And when we are able to score this helps us keep it really objective, so that when we look at events, was this really a one-off? Do we really need to change some big process? Or, maybe it's a pinch point with the finger. The pinch point with the finger, maybe that is something that would happen again and again and again. And so there's a major probability of severity of it happening, or severity, and then of it happening again. And then again, if you do not measure and track, then it's merely a discussion. And so action items that we track. So some of the things that we track, the description, contributing factors, who's the owner? This is a very important one in your RCA process. Who's the owner of the action item? If you don't give someone if you don't give someone, say, hey, you're the owner of following up on X, Y, and Z, then everyone thinks, oh, it's her job or it's his job. And so giving someone the owner of that specific aspect is very important. Also, a target completion. This is something that, you don't want to have just vague, well, we hope to complete this by the end of the year. No, we want to complete this by Q1, by Q2, or within the next 2 weeks. And then one of my coworkers on the RCA committee, she puts actual completion date, because you have your target completion, and sometimes we have some targets that we want to hit, but then we have our actual date of when we hit the completion date. All right, so for those of you that are Friends fans, this is where we pivot. We went from the RCA team that looks at all the events that actually happen at SMIL, the patient got their finger pinched or what have you, and then we pivoted. This is where we're trying to move that couch up the stairs, and we went from a reactive to a proactive approach, and it came the pivot. So this is when we formed our FACT committee. And what we gained from forming the FACT committee, and as a reminder, the FACT committee is the failure analysis critique team, is that we took that for the most part, the same RCA team, but we were able to have a proactive approach. And within doing that, we noticed that we had reduced stress within the team. So there was no direct ownership. We didn't have a patient or an employee get hurt. And so because there was no real ownership of a problem, if you will, we were able to relax a bit. And this allowed for more thoughtful and a less reactive discussion. We noticed that we had stronger engagement from the team, stronger curiosity and participation. It definitely felt more collaborative versus investigative. And this is where true innovation happened within the walls of SMIL. By solving roadblocks and problems that we didn't know existed, we really became innovative. And dare I say, we had some fun. When we formed the FACT committee, I noticed that we were enjoying the process. Again, with reduced stress, it just nothing happened. It's more of a pretend, if you will. Let's assume this could have happened within our walls, and we were able to really have some fun with the process. We formed our failure analysis critique team in early 2024, and the team members are the chief operating officer, which is myself, the director of clinical services, our quality administrator, our nursing manager, and then other staff based on the incident that we review, and then also the medical director based on if needed. And our mission is to stay alert to imaging incidents that happen in the public eye, to ensure that we remain informed and responsive. And we review events from an administrative and operational standpoint to answer the question, could this happen at SMIL? And here's a picture of a pretty big event that happened, I believe, in California with an ICU bed and an MRI machine. Okay, so our first case study that we reviewed as the failure analysis critique team was, it happened in our backyard in the Phoenix area, a friendly competitor. There was a technologist at one of the centers that mixed up Valium and gadolinium, which is MRI contrast, in an outpatient imaging center. So a little bit of homework. So before we go into the event that happened and before we dive into the event, I want to give you a little snippet of what it's like to be on the FACT committee and what we do before the meeting process. So we find what we can. Again, we're looking at articles, we're looking at news briefs that happen locally or nationwide or even worldwide. So we find one that looks interesting and that could perhaps happen within our walls. And then we send out the articles to the team as homework before the meeting. Now, again, I'm a big fan of when you have a meeting, you don't want to spend time reading the article. I mean, you want to do all of that beforehand. So it's important that you send out those articles before. And then when we get to the meeting, we fill in the gaps with our own protocol. Now, when you're viewing the news articles or radiology business management articles, or Radiology Today, or whatever articles that you're reviewing, there's not a lot of details. And so in the beginning and during the inception of our FACT committee, we had decided that we would fill in the gaps with our protocol, because we are assuming, because we are pretending, if you will, that this happened within our walls. Then you want to fill in what you don't know with your protocols and what you would do within your organization. We consider all the possibilities. We bring big, huge sticky notes and we put them on the wall, and we have one for operational and administrative. One thing that we learned pretty immediately was that you can't just look at things from an operational lens. You really do need to look at it from an administrative lens, because there are times, especially these big events that hit the news circuits, that there are some things that some changes that you can make, or some lessons that you can learn from how people handled or didn't handle events. Of course, we document. We save, and we then communicate any changes that may result. And we never let a good crisis go to waste, because we like to learn from others to prevent our own. Okay, so back to this first case study. This happened in our backyard, and basically, like I said, a radiology tech administered Valium instead of contrast prior to an MRI scan, and basically OD'd the patient in a life-threatening overdose. Now, this hit the news in Arizona, and I want to say that we didn't pick this one because it is a competitor of ours. We picked this one because, although it's a competitor of ours, those technologists, those employees, I mean, those patients, it could be something that happened within our walls. So again, it's not a shame on you type situation. It's more, whoa, could that happen here? And if yes, how can we prevent this? So upon looking at this, and again, we don't know much, because you can see this, that obviously this came much later because there was a lawsuit. We don't have a lot of details, but again, we just looked at our process. And some issues that we identified are that the different forms of Valium in the centers. And so a little bit, if you're familiar with the way that Valium is administered, and maybe not, there's two different ways. There's a vial, which is a multi-dose vial, or there's a carpujet. A carpujet is it's a single-use pin, and you only give it to one patient. And so we identified that within our walls, we have two different forms of Valium. The multi-dose vials, which do look a lot like the gadolinium vials. I mean, they're the same size, not really the same color, but very same size, and could be mistaken for one another. And then we have the carpujets. So that was something that we identified immediately, that yes, we do have two different forms. And one thing we also noticed was that all Valium, obviously it's a controlled substance, it needs to be locked up, but also contrast needs to be locked up due to state regulations. And so that was something that we thought, man, we should look at this, because is Valium locked up with the gadolinium? Because if so, then yeah, someone could grab a bottle thinking that, hey, this is Valium versus this is gadolinium. Another issue that we identified was that identical syringe sizes is used for that multi-dose Valium. So when you're using that vial of Valium and then the vial of gadolinium, you're using the same syringe to pull it up. So again, when you have a liquid in a syringe, perhaps that could cause some confusion as well. There was some inconsistent syringe labeling, some gaps in some paperwork workflow. And then one thing that we noticed here is that the patient had to have the Romazicon. When you get an overdose, very, similar to Narcan, Romazicon reverses that drug so that you can come back. And so we wanted to look at the drug reversal workflow. We had refined this many years ago. We felt like it was good, but perhaps it wasn't as clear as it could have been. So some opportunities to improve. Again, when we have the two vials, so we had the multi-dose vial, which you very well could draw too much up and overdose somebody, or the carpujet, which is a single carpujet. We had restricted these to nurse administration only. This is something that we did a long time ago, but wanted to do kind of a procedural pause and look at this to say, we want to make sure and do a sweep that the multi-dose Valium is truly restricted to nurse administration only. And it was. Carpujets were designed for sites where the on-site radiologist administered the sedation. Locked cabinets. I brought this up that you have to lock up the gadolinium, but you also have to lock up the Valium. And so we performed a sweep of all of our sites that perform sedation and Valium administration. And we performed a sweep to ensure that there was not gadolinium stored within those cupboards. Luckily, there was not, but it was a good moment for us to not just assume, but instead to pause and go and actually check to make sure that everything is the way that it should be. Now, one thing that we did do is that we changed the syringe sizes. So the nurses were using the 5 ml syringes for the administration of the Valium, and we determined that that is the same as the gadolinium syringe. And so we decided that the nurses would now use 3 ml syringes because you would not draw up gadolinium in a 3 ml syringe. So in doing this, it made it very different. You knew that this was not a liquid as a technologist that you would inject. It would need to be a nurse injecting. And we implemented a labeling system. Now, the nurses are the only ones that can administer Valium. And even in the case study, that's the same there too. It's by nature of our licensure. However, when you inadvertently draw something up, of course, this technologist did not mean to do that. And so even though the nurses are the only ones that administer diazepam Valium, we implemented a labeling system so that in the event the nurse by chance set something down or what have you, that diazepam would have a yellow sticker on it indicating that this is not gadolinium. This is not, everyone would know what this was. And then upon multi-dose check-in, so when we did get those Valium that are in the syringes that look very much like a gadolinium syringe, then we would place an orange sticker on each vial to deter medication mix-up. So not only were we putting the sticker on the syringe, but we now put stickers on the vial upon receiving the medication when it's stored and locked up. Again, just another fail-proof to avoid any type of mix-up. Some more opportunities to improve. We updated our drug cards. So we have some job aids that, kind of help people with, if it's your first, it's just a job aid card. And so we updated those job aids with multi-use Valium is for nurse only, so that you would know if you were at a site without a nurse and you needed the on-site radiologist, that would be for nurses only. We took the moment because this presented us with a lot of opportunities. So we took it as a moment to give our nurses some up training and some education. Number one, never to walk away from any type of Valium, whether it's a Carpujet, whether it's multi-dose or anything. It's a controlled substance. And, not just because it could be mixed up, but it's something that we track, and it's very important that we know where all the doses went. And so just a reminder to our nursing team, never to walk away from a controlled substance. And if they got pulled away for an emergent situation, take it with you or lock it up. So let's say they got pulled away because there was a reaction or someone needed something urgently. We reminded the nurses that put it in your pocket or go lock it up, because again, it's Valium. We need to make sure that we're accounting for every dose. Valium logs were reconciled, signed, and scanned in a timely manner. Again, these were just reminders for the team, things we were doing already, but reminders for the team. We also implemented a sedation timeout procedural pause. So before you give the Valium a procedural pause to say, hey, this is what we're doing, and inform everybody in the room that this is what we're doing. These are some nuances just to the workflows of SMIL, but felt like it was important to note as well. We removed the sedation form from our iPad check-in system, again, just to make it so you could do that procedural pause. With the iPad in the MRI environment, you couldn't do that. And we distributed Romazicon at the sites that have 2 MRIs. Again, something that we did pretty well. We have these pouches, and we just, upon looking at this, we thought, wow, what if you needed it and you had already used one? It's kind of like an EpiPen. If you have one, you usually get 2, so that if you use one, then you have one just in the wild event that you need it again right away. And then we retrained and acquainted everybody on the drug reversal protocol. Again, it's not something that you do very often. In my career, I think I've seen in the past 20 years, I think I've seen Romazicon, the drug reversal, once, maybe twice. So again, it's just a good moment to just pause and remind everybody how to use that drug. So that was a lot, but within that one, and our very first case study of our failure analysis critique team, and again, this Valium administration, it's something that we do well. We already peeled back over the last 15 years. We used to administer Valium at a lot of sites, and then we realized that having it at key areas just made us more successful. And so this truly was an area that we felt pretty good that we were pretty good at what we did. But even then, we were able to do this analysis, and within that, in this first case study, we were able to have 4 uptraining opportunities, which I just talked about, 2 workflow mitigations, and 4 tangible changes, all of which increased our patient and our staff safety. I know that we always want to increase patient safety, which is very true. We want to have the most safe environment for our patients, but we also want to have the most safe environment for our staff as well. So this was the measurable impact on this first case study of our failure analysis critique team. It was just this is what made us really think that, gosh, we need to keep doing this. We need to dedicate to this failure analysis critique team and keep looking at case studies, because this one event that happened in our backyard really did yield some great success for us. So some other measured outcomes since 2024, the inception of our failure analysis critique team. If you see on the right here, these are the fact events that we reviewed. Number 1, that was the Valium overdose, which happened in Arizona. And that happened in 2021. As we know, when litigation comes, when lawsuits happen, it's not usually right when it happens. You learn about it years later. And so that was the first one. The next one, again, happened in our backyard, and this is kind of what started this for us. But in 2022, there was an MRI safety event that involved an Arizona inmate that was the belly shackles were not taken off, and the inmate was pulled into the MRI machine. And then actually the officer that was with the inmate went to go help and had a gun. And then the gun, it was just lots of mistakes. So we reviewed that one as well. In 2022, there was an event, the hospital bed, which is that picture that was on some previous slides, that happened with the hospital bed in California. We reviewed that one as well. And there was a fire fatality during a hysterosalpingogram in 2024. This one happened overseas. We reviewed that one. Now this one was challenging. This is where we learned that Chat GPT and AI is our best friend, because it was in a foreign language and we couldn't review some of the news articles. And so when you can import those news articles into Chat GPT or Claude or your favorite AI, then it basically translates it for you, which is incredible. We also reviewed an outpatient reporting error that led to delays and ultimately an infant death. So this one wasn't anything that happened on site. This was a reporting error. So, transmission, they thought that the report was transmitted and it wasn't, because of a failed fax. And so we reviewed that one. And then I have a colleague that sent me this one. And so we reviewed this as well. There was a burn those stickers that people put on they're like freckly stickers that people, cosmetic stickers that people put on their faces for concerts or what have you. Basically, you apply them like a temporary tattoo that caused a burn in a hospital setting. Now, again, it was mentioned before. I'm an MRI tech by training, and so naturally, a lot of these they are involved with MRI. I'm an MRI safety officer. We do plan to also review the one with the chain that happened in New York. That one that was tough, and that's something that we do plan to review as well. So within reviewing these at SMIL, we were able to address the volume administration and storage updates, which we just talked about in length, increased door safety and discussion of testing items, to make sure that they're non-ferrous, training guidelines and updates for multiple departments, manager checklist for fire safety and electrical checks. That one is attributed to that oxygen fire overseas. We reviewed reporting errors and process escalation on weekends and closures. That one is about the infant death and the delay in the report. And then MRI staff training on metallic cosmetic sticker protocols. Obviously, this one just happened, and we reviewed that with the staff to make sure that when you're getting rid of stickers on faces, that you get rid of the whole thing so that you can prevent burns. So what are the next steps for you and your organization? I implore you to assess your current state. Who is conducting RCAs at your organization? And is the process consistent? Is it documented? Who's a part of the RCA team? And then that team, whether it's that team, I encourage for you to use that team, maybe an expanded team, but that team, and then shift from a reactive to a proactive approach. When you expand beyond your own events, and start monitoring external events, and then ask yourself, could this happen here? Some of them, no, they can't. They just can't happen within my walls because, again, we're not a hospital. So that hospital bed, we could have taken that one. We didn't get a lot from that one, but we did review it because we felt like it was important. But again, answering the question, could this happen here? And then learn from others. Never let a good crisis go to waste. And even more, learn from the mistakes of others to prevent them entirely within your organization. So again, let's review the objectives today. We understand the importance of root cause analysis and how to build a fact committee for your organization. Apply case studies that drive measurable impacts. At SMIL, I encourage you, when you get the slideshow here, you can use ours, you can Google them. They're very well-known cases, and then apply them to your setting. And then use tools and templates to facilitate team discussions and track interventions. I would love to know if there were any questions.
Yes, we do. Just a comment, Megan. I really like that. There were so many things I was seeing how this addressed the Baldrige criteria. Of course, I'm always thinking that, but certainly under the operational efficiency and category 6 and how in reducing risk. But I kept being drawn back. I had the criteria open. There's a question around blind spots, and the way that you've done this in a proactive way, you've probably identified several blind spots through this process that you may not have been even aware of. So I really enjoyed your presentation, and thank you for that. We do have a question for Doug from Doug. His is, what tools do you use as part of FACT? And he put failure mode and effect analysis. Is that one of the tools you use? But what are some of the tools that you use on that team?
So we basically use all the same tools that we use through our root cause analysis. So, basically the same thing. We're just going from a reactive, so something actually happened within our walls, to a proactive. So essentially, for all intents and purposes, it's the same tools that you would use for your RCA teams, which I showed a few of you there.
Thank you. Any other questions? Well, I'm going to go on and share about our next webinar, but if you have questions, you can still share them. I think you had a QR code here, Megan.
Yeah, I would love to connect. If there are any questions that come up later, or you want to just have a discussion about what we're doing or events that have happened or really anything, I would love to connect. My email address is here. That's my work cell. Find me on LinkedIn. Would love to connect with all of you.
Well, thank you so much, Megan. You really presented really, I think, a very proactive, valuable tool for everyone. So thank you for sharing this. Okay, so next month we have Dr. Daryl Watkins, who will be presenting on co-creating leadership, a followership framework for performance excellence. And that will be on July 16th. And the link here to register, and I will also send it out to all of you after the webinar. So we hope you can join us next month. And then on behalf of all of our programs, thank you for joining us today. I have provided the contacts for each of our programs that support this webinar. So if you would like to get involved with your local program, please reach out to the appropriate contact. If your program is not listed here, you can reach out to me and I can connect you. But we would love to get you engaged in our work to help organizations improve performance excellence and using the Baldrige framework to drive assessments. One last chance. If anyone has any questions, I'll pause. Okay, thank you for joining us. Have a great rest of your week. Thank you again, Megan, and we will hopefully see you next month. Bye, everyone.
Thank you.